My name is Dr. Paul Richardson, and it's my pleasure to share with you some of the data from our determination study, which has been presented by my colleague, Dr. Jeffrey Zondler, here at the ASH meeting in San Diego. In the study, we've looked at the subgroup analyses across the board for the trial. Just to remind people, determination showed that in the setting of triplet therapy, RVD, that you could delay transplant or use it early in our trial. I see no meaningful difference in survival, at least to date. However, what you do see is a dramatic progression-free survival benefit if you do use transplant early. However, as we looked at this further, we noticed that subsets of patients seem to derive less benefit than others. And in particular, the hazard ratio for our patients who are African American, our largest enrolled cohort actually of patients, 20%, which is one of the largest ever done to date. We were able to demonstrate in that subgroup of patients that there were some important differences in how transplant either served them well or otherwise. In particular, we found that in subgroups of African American women who have high BMI, the three-drug platform of RVD was seen remarkably well. However, in the transplanted patients of the same characteristics, the median progression-free survival appeared shorter than the median overall. I think we have to be very careful how we interpret this. It's certainly hypothesis generating, and it helps us better understand that one size does not fit all. And in particular, now that we're moving into the era of quadruplet therapy, with RVD, for example, combined with daratumumab or combined with other drugs like isatuximab, we can think of these quadruplets providing patients with even better therapy out front. And in that context, if there's a patient in whom transplant can reasonably be kept in reserve, these data would certainly support that approach being considered in each patient's case. So the upshot of Jeff's presentation is really to emphasize the value of transplant, that going early does in fact generate progression-free survival benefit, but without a survival difference, at least to date, these important subgroups where transplant may be reasonably kept in reserve may in fact benefit from such an approach. More studies to follow, and perhaps most of the most important aspect of this work is our focus on Duffy null. This is a particular phenotype expressed in patients of West African heritage, and in this particular group of patients expressed with a frequency of up to 60 to 70%, we see actually some important differences in terms of their pathobiology of their disease on the one hand, and potentially their tolerance to treatment on the other. This is very much an area, however, where more studies are needed, and these are ongoing, and we hope to report more to the hematology community in the near future.